I've sensed a trend over the last couple of weeks that with the growth of Omicron, explosive transmission, the fact that we're seeing breakthrough cases and vaccinated and even boosted, and we're experiencing a surge in hospitalizations and demand on the healthcare system. There seems to be this trend of folks just throwing up their hands. And to be honest, this is coming even from leadership at the national level, I think in the federal government, and coming from folks who've been leaders in the public health epidemiology community throughout the pandemic. You even have folks like Tom Frieden tweeting things saying that this is completely different and not the threat that COVID was previously. And I think that this idea of surrender in the face of Omicron is not the way that we should be going. If anything, Omicron and the threat that we're facing now should steel our resolve to take even bolder action, which is necessary to protect the health and safety of our communities and the functioning of our health system, and even the functioning of economy and society as we look at the potential impact of absenteeism and disruptions on critical infrastructure. So I want to take a few minutes today just to point out how we do that and how we don't give up to these forces who appear to be just ready to take their ball and go back home because it's too overwhelming. And the first thing I think we need to be careful about is these ideas of minimizing Omicron itself and minimizing the health system impact. I think we've all heard now that Omicron is milder, and that in a way I think is an attempt to surrender, that it's a way to say nothing is important in what we do now because it's a milder disease. And hopefully I've pointed out on a number of these briefings where milder does not mean less impactful if you're talking about severity of disease on an individual basis, especially when you have a virus that's so much more transmissible and able to cause so many more cases. The next place where people have tried to minimize this is in hospitals, and where I know that we all who work in the hospitals and are in there on a daily basis feel the strain and the weight on the hospital system now like we've felt it really at no other time. And so for people to tell us, well, those people are just in there, because they are just, sick for some other reason and happen to be infected with COVID. So this idea of they're in the hospital with COVID, not because of COVID, it just is inconsistent, certainly, and discordant with what we all see when we walk into the hospital. And so again, many of these folks are telling us, don't believe what you see, don't believe what your eyes are telling you, believe what we're telling you. And I think we need to push back on that. So this idea of people are just hospitalized with COVID and not because of COVID. There was an article in the New York Times a couple of days ago where one of the hospital administrators from a New York hospital said up to 65% of their COVID admissions were for some other reason, and they just happened to be COVID positive. Now, this isn't based on any science, right? This is not actually even an epidemiological study. This is just the opinion of some New York hospital administrator who knows talking to whom. But this is caught on and appears to be taken as gospel now. Well, if you look at the math, that makes absolutely no sense. Let's think about what the COVID rate is in New York City right now. It's peaked at around 400 cases per 100,000 per day. That's where it's been for a while. And if you think that there's probably in New York, at least, about a 2.5-fold under ascertainment of cases, I think that's probably pretty accurate for New York. They test at a rate higher than almost any other state. And if you look at health or data from staff in nursing homes and long-term care facilities, that's about where the predicted rate of infection would be for that group, who is one of the most monitored in the community. And so we can go into how I came up with that a little more detailed later, but I think that's a relatively accurate estimate of the under ascertainment in New York. So therefore, in New York City, that means the true daily case incidence is about 100,000 cases or 1,000 cases per 100,000 per day. It's 1% per day of the population being infected. That is, obviously an astronomical number, but probably around where we are. If you think that the average case of Omicron appears to shed virus for about 10 days, some people clear earlier, some people clear later by PCR, about 10 days seems to be around the average, then based on that assumption, at any given time, people walking down the street in New York City, assuming that people with COVID are still well enough to walk around, about 10% of the population should test positive. So that's your background rate for what percentage of folks should test positive. Now, this is also weighted a lot towards younger and healthier people who are much more commonly infected. They have the highest proportion of infections of anybody in the community. They're also the least likely to get admitted to the hospital. So if anything, we're dramatically overestimating the background rate that should occur in the hospital. As you can see, the vast majority of cases in the community occur in those ages between 18 and 49. Now, we probably don't detect nearly as many of the true cases that exist in kids. But the point is, people who get admitted to the hospital are generally people over the age of 65, as we all recognize. People who are most likely to be infected with COVID in the community are people between the ages of 18 and 39 or 18 and 49. So again, we are overestimating what the background rate would be in the hospital. But be that as it may, let's take a look at New York State and New York City specifically and see what if that expected background rate was true, what percentage of their hospitalized should be incidental COVID infections. You can see that right now, as of 2 days ago, New York City had 12,000 patients in the hospital, roughly. About half of those, or 51%, had tested positive for COVID. Now, if you assume that that 10% background rate is true, only 1,200 hospital admissions should have been incidental COVIDs, or 19%. So there's a difference of 30% of their inpatients who have COVID who are above the background rate that you would expect. So something is obviously going on there. Either for some reason, there's some unrelated correlation between the risk of COVID positivity and the risk for hospitalization, or being positive for COVID actually has a direct impact on your chances of being hospitalization. And I think all of us would probably agree that the latter has to be true. And the reality is that probably many of these people who are being labeled as incidental COVID are actually admitted because COVID has contributed to their demise, either exacerbating an underlying medical condition or directly causing the insult that has landed them in the hospital. So this idea that most COVID patients in the hospital are actually incidental is just ludicrous when you actually look at the math. Now let's look at what we're seeing in impacts to hospitalizations across the rest of the country when we have people trying to minimize what the impact on hospitalization is going to be. You remember the decoupling factor calculations I did last time, looking at states in the east of the US compared to Europe. I went ahead and did some additional calculations for a bunch of states in the South who have now started to peak, or at least are at rapid acceleration of cases and hospitalization. And I think what's important to note here is this decoupling factor. So South Carolina, you see it's 1.1, Louisiana 1.9, Georgia 1.9, Alabama 2.2, Texas 1.6. And so remember, that's the ratio of cases to hospitalizations during the previous waves, generally wave 2 in the winter of 2020, 2021, compared to the ratio of cases to hospitalizations now from Omicron. And you remember in Europe, at least in the UK and Denmark, that decoupling factor's over 4. So essentially right now, those countries are experiencing fewer than a quarter of the expected hospitalizations that you would predict based on the number of cases they have, if their hospitalization rate were the same as the previous wave. On the East Coast, this is only a little bit above 2. So that means only half of the expected hospitalizations, not a quarter. And then in southern states who have lower rates of boosting, as you can see there, it's even lower. And so for most of the country, you can probably expect that decoupling factor is going to be a little less than 2. So only a little less than half of what was experienced in the previous wave. And for most places, as we calculated in Nebraska, that is probably going to overwhelm the health system. The next thing I think that people are trying to do, again, is to minimize the role of kids and to minimize the role of schools in community transmission, saying that it's not going to make a difference if we send kids back to school and crowd them together in the highest density environment that we have in our community. And again, on just based on common sense, the idea that that is true is just patently hard to believe. And I think data, and we've gone through lots of school data previously, but this I thought was a good graphic representation from Germany, looking at, it's a heat map of ages and case incidents in the community for the last couple of waves. And you can see here that these community epidemics are, again, being driven primarily by kids. The highest rates that we're seeing in Germany, and in Germany, they're doing a better job of actually testing children, where we don't necessarily do that very much in the US. You find that the highest rates of COVID infection in the community are occurring in school-age children, and to a lesser extent, younger adults, school age and college age, university age children. Those are the groups within the communities that are initiating transmission and driving transmission into the community, just as we've discussed, just as the data from the 1970s in influenza pointed out. Influenza outbreaks in the community start in schools, and then they progress through older decades of ages until they eventually make their way into the more vulnerable older populations. That's what's happening with COVID-19 as well when you actually look. The next thing we're being told, don't believe your eyes, right? Just believe what we're telling you, is these massive rates of hospitalization in kids that we're seeing on the East Coast are nothing to be concerned about. They don't exist, and that the impact on kids is still not going to be significant. So again, I've put up some data in the last couple of briefings about those rates of hospitalizations on the East Coast, how they're greater than we've seen. I think it's also important that we keep in mind that we don't know a lot of the long-term impacts on children, just as we don't know a lot of the long-term impacts on adults in terms of long COVID and other long-lasting health effects. This study just came out of the UK, looking at surveys of kids who had been diagnosed with COVID and had tested COVID negative, and compared at 3 months the incidence of various symptoms in those cohorts. And what they found is that a significantly higher proportion of kids who had tested positive for COVID had long-lasting symptoms at 3 months. You can see that 14% of those kids, 14% more of those kids had at least 3 symptoms in the survey score. And they also reported in a quality of life surveillance tool that they had significant problems with mobility, doing usual daily activities, or pain and discomfort. And if you look specifically at some of the findings, you can see that things like fatigue, shortness of breath, headaches, and neuropsychiatric issues such as confusion, disorientation, sleepiness were much more common in kids who'd been diagnosed with COVID than kids who hadn't. So again, just more data indicating that long COVID in kids is a true phenomenon, and that the incidence may be much greater than we've appreciated, and that if we are allowing millions and millions and tens of millions of kids in the US to be infected because we're not taking all of the precautions we could to keep their school environment safe, then the burden of that long-standing disease in this pediatric population unfortunately falls on our inaction. I think the other good thing about this paper, and I won't go through it, but it'll be in the slides for you to look at, gave a really good compendium of all of the different studies that have looked at long COVID in kids. And you can see there's a pretty decent list and all of the findings that are there. The next thing I think we've been essentially told to give up on is testing. Testing just doesn't matter anymore. We should just, stop testing, or maybe we can just use these antigen tests because they're good enough. Well, and the other thing that testing isn't important for is to allow people to go back into the community out of isolation, right? So we've been told, let's just let's just surrender and give up on this idea of isolating sick people or quarantining close contacts. And the CDC came out with their 5-day guidance. Well, that 5-day guidance, as I mentioned, really wasn't based on any science. And now here's more science to directly refute it. This is a study that came out of the Japanese National Institute for Infectious Diseases, looking at cases with Omicron and looking at viral shedding by PCR after initial clinical diagnosis based on testing or onset of syndrome symptoms. And you can see that by day 7 to 9, 94% of these people were still shedding virus detectable by PCR. Not only that, 12% actually had culture retrievable virus. That means, no doubt, no kidding, live virus that you can culture in a cell culture, which is a pretty high bar, to be honest, to measure infectivity. There is no question that if you can culture virus out of your respiratory secretions, you are highly infectious. And people are still infectious even if you can't culture for a variety of reasons. This virus, it's hard to grow in cell culture, to be honest. So it's much easier to grow in your own native respiratory mucosa. But you can see that even after the onset of symptoms, 100% of people at day 7 to 9 had positive PCR and 20% had positive cultures. If you look at CT values there, either from days since diagnosis or days since symptom onset, at day 7 to 9, the majority of people tested still had CT values under 30, which I think most experts would agree is an indication of enough virus. Remember, lower CT means more virus. That's enough virus to make somebody pretty infectious, a CT under 30. I think, I would actually say under 34 is a pretty good indication of infection, but under 30 is no question. So clearly what the science is telling us is people are not safe to go back into the community at day 5, and we should be either extending that isolation or we should be testing to release with a reliable test like PCR. That's the other thing that we've been told to give up on, again, as I mentioned, is testing. And again, more data indicating that the antigen tests that people are trying to rely on are very poor indicators of early disease, asymptomatic infection, and the potential for transmission. So this was a study of 30 people in a couple of different cohorts that was just published in preprint several days ago. I had mentioned some of these data, but now it's actually out in at least in preprint server. And this was, again, 30 folks tested on a daily basis with antigen test and PCR. And you can see that for the first 2 days of their positive PCR, in which many of those had documented transmission to other people. So this wasn't just PCR positive. This was PCR positive with very low CT values, as you can see there on the left, certainly below, almost all below 30. And able to infect, and actually several with documented cases where they transmitted to somebody else during this window of time. But during that 2-day window, 100% of their antigen tests were false negative. So clearly indication that these antigen tests are not very reliable in that situation of early symptoms or asymptomatic, trying to measure whether somebody is an infectious risk to others. So PCR is really the test that we should be using. And finally, we can't forget the impact of vaccines and the importance of increasing vaccination rates, particularly boosting rates. There were a couple of studies that the UK Health Security Agency characterized in one of their recent reports. Again, this was one looking at boosting with various vaccines based on various primary regimens. When we look at people who were vaccinated with Pfizer initially and then boosted with Pfizer or Moderna, which is most directly applicable to the US, you can see that vaccine effectiveness against hospitalization is still excellent. So 88% for people who had been boosted with a third dose in terms of vaccine effectiveness against hospitalization. So the vaccines are still working incredibly well to keep people out of the hospital, even the highest risk, once you're boosted, who are the ones in the UK who've obviously been boosted most quickly. And then the New York Times this morning had a great piece that had figures detailing the protective factor from vaccination for both cases and hospitalizations when you look in New York and Seattle. And you can see a massive difference both in your risk of becoming a case and an even more massive difference in your risk for becoming a hospitalized case if you are fully vaccinated compared to unvaccinated or not fully vaccinated. So those are the things that we need to keep in mind we should not give up, and we should not surrender in our fight against the Omicron. I think that we should increase our resolve, keep fighting, and let's keep our health system functioning and reduce morbidity and mortality. Thanks.